Hello, my name is Giorgi Goletiani, and today I'm going to talk about objective pain assessment. Table of content for my presentation is on this slide. So first we are going to talk about what is pain. Next, we're going to discuss why we need objective pain assessment methods. And after that, we're going to talk about individual papers. First, we're going to talk about evaluation of pain from facial expressions. Next, from PPG signals, from EEG signals, different applications for that. And at the end of the presentation, we are going to talk about chronic pain state prediction. So what is pain? Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. This is the definition by the International Association for the Study of Pain, and the key word here is damage. Pain has information about the damage in human body, and we as physicians are very interested in that information because it can lead to better diagnosis and better treatment. So that is one of the reasons why we need to have objective pain assessment tools. Another reason would be the fact that subjective assessment of pain can lead to incorrect conclusions and incorrect management in form of undertreatment, which leads to unnecessary pain and suffering, or overtreatment, which has led to opioid epidemic. It could also be very helpful in nonverbal patients and patients who are cognitively impaired, who cannot effectively communicate what they feel. It can also be used to monitor effectiveness of different pain medications in different patients. Of course, the potential in research and legal and ethical considerations should also be mentioned. There are some individuals who report feeling pain when they actually do not feel anything. They do so for external gain, which could be opioid medication or perhaps a financial reward from an employer. So now let's talk about the methods themselves. First, we're going to talk about facial expressions. When people experience pain, their facial expression changes, and that change can be used to assess the pain that they are feeling. The research shows that when people experience pain, they contract certain muscle groups. These muscle groups are called action units, and they are then you can see them on your screen. These are action unit 4, 6, 7, 9, 10, 25, 26, 27. These seem to be the consistent components of pain-associated facial expressions in both cognitively unimpaired and impaired individuals. Actually, it was found that cognitively impaired display more pronounced and easier to detect changes in facial expressions. So what researchers have been able to come up with is the PSPI score. Below is the formula for that, and as you can see, it is the sum of intensities of different action units. Now the hard part is actually grading intensities of each action unit on a scale of 0 to 5. Unfortunately, not everyone can do this. In fact, we need a trained eye. We need an expert to do this, and this is not something anyone can become an expert at in a few days. Therefore, at first sight, it might not seem feasible that this method will be broadly adopted. But fortunately, the advancements in the AI and specifically deep learning have made it possible for computers to evaluate PSPI scores from facial expressions automatically without any human interaction. On this slide, you see the current state of the art. In this specific example, researchers were trying to assess shoulder pain from facial expressions. And as you can see, accuracy they were able to achieve was more than 90%, and MSC was lower than 0.04, which is very low. This is a very good result, and although we would like the accuracy to be closer to 99%, this is still a very promising result. Maybe in the future, special cameras will be able to track patient pain levels 24/7 at the hospital and make it easier for all patients to get adequate medication. Not undertreatment, not overtreatment, but just the right amount of medication. So another method researchers tried to use to objectively assess pain was to use the PPG signal from photoplethysmography, which can be obtained from any pulse oximeter. The example of a pulse oximeter is shown on the slide here. Photoplethysmography detects blood volume changes in the microvascular bed of tissue. It detects the wave of blood that comes in the tissue as the heart contracts. And we know that cardiovascular system is affected by the respiratory system. So that is why we can obtain the respiratory signal from the PPG signal. And because the respiratory activity changes with the level of pain the human experiences, these data can be used to estimate the pain level. On this slide, you can see the PPG signal on the top and the extracted respiratory signal on the bottom. The researchers focused on different features from the respiratory graph, such as peaks, the number of inhaled peaks, the mean value of the signal, the maximum value, the minimum value, the range, standard deviation, and etc. And it turns out these features are very predictive of the pain level. Now, here's what I mean. With the features from the previous slide, researchers were able to use different machine learning algorithms, including SVM, which was able to achieve on average 80% accuracy when trying to differentiate between 3 different pain levels. Now, 80% is not super high, but it has to be said that the researchers had data from less than 100 patients. And as we know, machine learning methods work best with a lot of data. So I do believe that with more data, the researchers could have obtained better results. So now let's talk about EEG. EEG is the most promising method of all. First, we're going to talk about a paper published in 2020 that talks about assessment of pain in healthy individuals. In this paper, researchers simulated pain using ice-cold water and recorded the corresponding electrical activity using EEG. Next, they had the subjects evaluate the pain level they were experiencing. Using these data, researchers were able to train a neural network that could correctly guess when the patient was experiencing different levels of pain. As you can see, the results they achieved are truly remarkable. Accuracy of almost 95% and F1 score of 94%. This serves as proof that EEG signal has information about the pain the human is experiencing. The next paper we are going to talk about was published in 2020. And in this paper, researchers tried to differentiate between no pain, radiculopathy pain, and patients with chronic lumbar pain who are good candidates for spinal cord stimulation. As you can see, the overall accuracy was 72%, but the trained model had an AUC of 0.96, which means that the model was very good at differentiating good candidates for spinal cord stimulation from others who didn't need this therapy. Next up, we have an exciting paper from 2018. In this study, a team of dedicated researchers set out to tackle a crucial challenge. Can a classifier be trained using only EEG signal to identify patients at high risk of developing central neuropathic pain after a spinal cord injury? The results are impressive, to say the least, because they achieved accuracy of 90%. As you may know, central neuropathic pain affects 40 to 50% of patients with spinal cord injuries, and unfortunately, there is currently no cure. But imagine the possibility if we could reliably identify people who are at high risk. The potential impact is enormous. It would mean that these individuals could receive closer study and potentially be offered preventive therapy. I also want to notice how the model the researchers trained focused primarily on the EEG channels from the left hemisphere when trying to predict the patient's risk for central neuropathic pain. Now, the implications of that are not currently understood, but that could lead to some revelations in the pathogenesis of this syndrome. In this paper from 2022, researchers aimed to determine the accuracy of identifying postherpetic neuralgia patients who showed resistance to various medications. They employed the KNN predictor, a machine learning method utilizing EEG signals, and the results were remarkable. The KNN predicted, as you can see, demonstrated an impressive 80% accuracy in identifying patients resistant to medications as early as 1 to 2 days into the therapy. This, of course, holds the potential to pave the way for the development of customized protocols, preventing overmedication in such patients and ensuring the right medication is prescribed accurately. The last paper we are going to talk about is a very recent one from 2023. Researchers wanted to identify pain state in patients with chronic pain. 3 out of 4 patients had post-stroke pain and 1 had phantom pain in amputated limb. As we all know, EEG has a limitation. It cannot fully see exactly what's going on in the deep structures of the brain. To overcome this, researchers utilized intracranial electrodes, allowing them to explore the electrical activity within the anterior cingulate cortex, or ACC, and the orbitofrontal cortex, or OFC. As we can see, the researchers were able to achieve good results with LDA technique. On average, area under the curve, or AUC, was more than 0.75, and the conclusion they came to was that intracranial OFC signals can be used to predict spontaneous chronic pain state in patients. One more thing I wanted to add is that researchers tried to identify if they could see any difference in how brain processes chronic and acute pain, and what they found out was that the ACC activity was more associated with sensation of acute pain, and OFC activity was more associated with chronic pain. But as you can see from this slide, acute pain state prediction with ACC and OFC neural recordings is generally unreliable, so we have to stick to EEG signals on that one. Thank you for watching.